Second speaker, also a dear friend of mine, somebody I've known for 27 years, is Dr. Scott Weingarten. Scott trained at Cedars-Sinai, joined with Cedars-Sinai to start a company that many of you know about called Zinx. Zinx was later sold to Cerner and then to Hearst. Scott went with them, and we were lucky about a year and a half, 2 years ago, to bring him back. He is the Clinical Chief Transformation Officer for Cedars-Sinai. Join me, please, in a nice welcome for Dr. Scott Weingarten.
Let's see. Terrific. Thank you, Tom. One of the reasons I'm here also tonight is for Tom, who I believe is one of the kindest, most caring, thoughtful people I have ever met. In the short version, I always tell people the world's just a better place because you're here, Tom. So it's a pleasure to be with everyone today. Tom shared some information about our physician organization. Tom asked me to share a few words about Cedars-Sinai Medical Center. I'm extremely proud to have the opportunity to work at Cedars-Sinai Health System, which includes Cedars-Sinai Medical Center, which we strongly believe provides very high quality care. Part of our mission is research, expanding scientific and clinical knowledge, teaching, educating healthcare professionals, and improving the health status of our entire community. Tom asked me to include a slide about me, and so I'm very proud to be a Bruin. I was born here. My father was a student here. I am a proud alum of the Fielding UCLA School of Public Health and was extremely fortunate to have Professor Torrens as my professor. Went to medical school here, fellowship, did my residency at Cedars-Sinai, and really Tom shared the rest. But I think part of my job as a Chief Clinical Transformation Officer is to align with physicians to improve the value of care, quality of care, patient experience, and patient engagement. Now, we heard from John about MACRA, and I think MACRA is changing everything in terms of care delivery and also alignment of physicians and hospitals. As John mentioned earlier, MACRA, the SGR repeal, passed by an overwhelming vote in the Senate and the House. You can see the vote up here. That means Republicans voted for it, Democrats voted for it. It meant everyone voted for it, basically. Physicians who care for Medicare patients, whether they be subspecialists or primary care physicians, can choose one of two directions. Direction one, they participate in merit-based incentive payment system, which has, John mentioned, has upside gain and downside risk, or alternative payment models. And alternative payment models have downside risk. 75% of Medicare payments must be in alternative payment models, or 75% of commercial payments by 2023. 2023 will be here before you know it. Bottom line, downside risk for all physicians who care for Medicare patients. That's hard, as John alluded to. You need investment, you need infrastructure to be successful, and that's why we're going to see, I believe, more integration, physician integration, more alignment between hospitals and physicians. So I'm going to talk a little bit about aligning with our physicians on our goals here. One of our goals is to keep patients as well and healthy as they possibly can be. And so there's an effort underway at Cedars-Sinai to identify our frail patients, our elderly patients, our most vulnerable patients, and not provide them with less care, but provide them with more care in their homes, calling them up. Mr. Smith, how are you feeling today? I'm going to send a nurse practitioner to your home. And for all of these patients, really, to make sure that they are as healthy as they can be so that they're doing what they want to be doing, whether it's at the beach or in their garden or spending time with their kids, grandkids, or at work or at school. This effort is being led by a couple of people here, Cynthia DeCulis, Sharon Izanaka, and by providing more care, we've found at Cedars-Sinai Health System a significant reduction in our admission rates. Patients are doing what they want to be doing. They don't want to be in our hospital. They want to be at home. And you can see here for Cedars-Sinai Medical Group under Tom's leadership, how we compare in terms of admission rates to what's called Milliman, which is the authoritative source of information well managed, which is top 5% of organizations in the country. So this is somewhat unusual for an academic health system. And then if we look at senior HMO or Medicare Advantage, again, low or relatively low admission rates by providing more care. What else can we do to align with our physicians? We've installed electronic health records. Significant effort, costs went into installing electronic health records in physician offices, in the hospital. So can we hardwire in information to provide guidance to our physicians while they're caring for patients that'll lead to better quality of care and higher value care? Think about almost a GPS or Waze. Those of you know in Los Angeles, we rely on Waze. I know I frequently do. Now the physician can override it, just like we can override. We don't have to follow Waze. We don't have to follow our GPS. But if we can identify tests and treatments that will lead to better quality of care at a lower cost, why not inform the particular patient? So we hardwired this in at Cedars-Sinai. We believe we're the first in the country as it relates to choosing wisely. American Board of Internal Medicine Initiative, 70 subspecialty physician societies representing over 600,000 physicians, where the information comes from physicians rather than the government, rather than insurance companies. And we find that when you hardwire that information into the electronic health record, physicians pay attention to it, and it changes care. And you can see a number of changes in care that we've experienced at Cedars-Sinai as a result of it. Another issue we heard from John, succeeding with risk-based payments is challenging, and many physicians are up to the challenge and accept the challenge, and others perhaps do not want to participate or may not succeed. And so what we've done is we've measured readiness for risk-based contracts or population health. And so we've looked, we're going subspecialty by subspecialty. We had to, if you would, invent our own criteria or evaluation system to really determine how well our physicians would perform with risk-based payments or being at risk, both for quality outcomes and for cost. So some of the criteria are adhering with choosing wisely guidelines. And those are guidelines where physician societies I mentioned earlier determine where the harms exceed the benefits or there are no benefits. It may not be of value to patients, and physicians should discuss whether to proceed or not proceed with the patient, get feedback from the patients. Readmission rates, adherence to quality improvement interventions, primary care physician surveys about how well that subspecialist might communicate with the primary care physicians, the quality of care, length of stay, severity adjusted cost, and then profile the physicians and let them know how they score. And you can see here, these are a number of the Cedars-Sinai cardiologists, and you see some spread in the scores. Again, the hope is through these systems of care, through guidance in the electronic health records, to enable these physicians to be as successful as possible with risk-based contracts. Again, that's where the alignment, the investment in providing the infrastructure is likely or hopefully will lead to success for more and more physicians. So we're setting up all these systems as the medical center and physicians align, because really physicians went to medical school really with one purpose, and that purpose is to provide the best possible care to every single patient. And this is a painting from about 100 years ago, a physician doting. You can see the concern that physician has for his particular patient. And so to set up the systems of care to enable physicians to do what they do best, what they want to do, to really evaluate the needs and provide the best possible care to every single patient. And then finally, we're aligning with our physicians on change, and we have a lot of discussions with our physicians, get their feedback. I think Tom put on a really remarkable retreat over the weekend where we brought all of our physicians together and discussed the reasons for change. And as we heard earlier from Tom and from John, the healthcare environment is changing. That train is going east. And if we want to have the opportunity to continue to provide outstanding quality of care to our patients and to members of our community, provide the best experience possible to our patients, and the definition of best experience is changing. It's changing all of the time. We'll, I'm sure, get into that as we talk about new ways of treating patients and diagnosing patients, many cases while the patient remains at home, and ensuring that that care is affordable, that we'll continue to have the honor and the privilege to be able to care for patients and members of our community for the indefinite future. Thank you very much. Tom?
Thank you.